So before that, I want to go over the confirmatory phase 3 study. These are studies versus docetaxel. Docetaxel is currently the standard approved therapy in the second line. So these are two studies, large studies, Codebreak 200 and Crystal 12. Codebreak 200, which has already been published, I'll show you the data, and Crystal 12, which is ongoing, where we looked at the activity of the G12C inhibitor versus a chemotherapy in the second line. And what was pretty disappointing in this study is that sotorasib had a response rate of only 28%. Far better than docetaxel at 13%, but clearly a drop from what we saw in the phase 2 trials of 37%. It's also important to note that the progression-free survival, how long someone's on the therapy before the disease progresses, was only 5.6 months. Again, better than docetaxel of 4.5 months, but still very short. And I think we need to do better for our patients. And then lastly, when we look at the overall survival, really the docetaxel, the chemotherapy, appeared to be better. And again, there could be reasons for this, such as crossover, patients then getting the sotorasib at progression. And this study was not powered. It wasn't intended to show differences between the survival in these populations. We talked about acquired resistance being really important. This is a patient of mine treated with a KRAS G12C inhibitor. You can see the mass in the left upper lobe, initially large and then regressed, but really quickly, after only about 4 months, had rapid progression or growth of the disease. And using liquid biopsy, and this is Dr. Awad's data, we've been able to show both point mutations in RAS as well as these bypass track mutations that we may need to target. And in very important data showed by Dr. Skalides again from MD Anderson, in that phase 3 trial of sotorasib versus docetaxel, when you looked at those patients who had other point mutations or other RAS alterations, such as KRAS G13 or KRAS G12D, those patients did not derive any benefit from sotorasib. So again, looking at the whole report with your clinician is critical in order to guide best possible therapy. Here's a quick look at some of the intracranial activity that we've seen from adagrasib. This is a patient of mine and a patient treated in Boston at MGH, where we see good activity of adagrasib in the brain. And more recently, we published the updated data set. This medicine has a response rate of 42% in the brain, and we're seeing durable responses in the CNS. We have not yet seen any data from sotorasib or other therapeutics in the active, untreated brain metastasis patient population. So really critical thinking moving forward. So how do we move these therapies to the frontline setting? Well, why don't we combine them with immunotherapy, which is what we currently use in the first line? And the problem with sotorasib, which is the KRAS G12C inhibitor combined with pembrolizumab, is that we see very high rates of liver toxicity, upwards of 35% or so, which make it very difficult to use this combination.